Ladies and gentlemen, we have the next lecture that features on the topic Transcatheter Interventions in the Neonates with Critical Congenital Heart Diseases. Our invited speaker from the People's Republic of Egypt is Professor Hala Marsafawy. She is a professor of pediatrics and pediatric cardiology and director cath lab at the Children's Hospital in Mansoura in Egypt. She is also head of the working group of the Egyptian Pediatric Cardiology.
Good morning. I'd like to start my lecture by giving my thanks to Professor H.K. Chopra and the organizing committee for inviting me to this distinguished meeting that we used to come every year. And I hope this will last forever, as long as you're having this meeting. This is my hospital, which is the Children's Hospital in the Delta, which is the north of Egypt. It's about 365 beds, dealing with children with all specialties. My talk today is going to be about catheter-based interventions in the neonates with critical congenital heart disease. And why these subjects? Because, as you know, the congenital heart is the most common birth defects, and it's the leading cause of death among infants and neonates and infants. And these infants and neonates presenting with critical congenital heart disease is about which is common high. And by talking about critical congenital heart disease, we mean that this congenital heart disease that needs interventions in the first months of life, and interventions we mean either catheter-based interventions or a surgery. And just remind you that the neonates is a very fragile subject. It's not like the infant, it's not like children, and of course it's not like adults. It's had their special unique features. And one of these, they are a response to physiological stress for circumstances rapidly and profoundly, with drastic changes in the pH, serum lactate, glucose concentrations, and temperature. So you have to be very careful on dealing with neonates with critical congenital heart. They have diminished fat and carbohydrate reserve. They have a higher metabolic rate, higher oxygen consumptions, and smaller functional residual capacity in the lungs, which results in rapid appearance of hypoxia when the neonate becomes apneic. Also, the total body water is greater than that of the older child, and the capillary system of the neonates had the propensity to leak earlier. The pulmonary vascular bed is nearly fully recruited at rest, and the lymphatic recruitment required to handle increase in the mean pulmonary artery pressure is unavailable. So the neonates may be more likely to maintain a blood pressure when in a condition of stress. So we don't rely on the systemic blood pressure on dealing with the neonates. We have to be fully aware and fully on our urge in dealing with the neonates with a congenital heart disease. The liver is immature, the kidney is immature, so the protein synthesis is reduced and the glomerular filtration rate is reduced, so the kidney and the liver functions are decreased. The neonatal myocardium is less compliant than in the older heart, so any increase in preload or increase in afterload will lead to congestive heart failure. These neonates, according to these pathophysiologic changes, will present with cyanosis due to atrial hypoxemia or respiratory distress and pulmonary edema and congestive heart failure. Whenever there is a pulmonary overcirculation and volume overload, there is shock whenever there is a systemic hypoperfusion, and there is respiratory distress and pulmonary edema whenever there is a pulmonary venous hypertension, and it may present with combinations of any of the above. So the procedures we are doing in the neonates, either atrial septostomy or septoplasty, there is a balloon angioplasty or valvuloplasty. We are placing stents and we are using the new hybrid techniques. The septostomy procedure, this is one of the oldest techniques in interventional cardiology, either balloon septostomy or a blade or a balloon septoplasty, dilatation of the atrial septum. The balloon septostomy, dealing with the infants or neonates with a congenital heart disease, the transposition physiology like TGA, transposition of great arteries, or a congenital heart with a transposition-like physiology, which is a double outlet right ventricle, or whenever there is an obligatory right to left shunts or a left-sided obstructive lesions. These patients should be stabilized first by starting prostaglandin E1 infusion, and this is, we either do it in the echo lab or in the cath lab, depending on the balloon we are using. So this is a patient with a pulmonary artery arising from the left ventricle, aorta arising from the right ventricle, and the pulmonary blood flow is maintained by the duct, We're starting with the Drashkin balloon or the Miller-Edwards balloon, starting with a small size. Put the balloon in the left atrium, drag across the septum. So increasing the size of the balloon and creating a large atrial septal defect with the flap moves to improve mixing between the pulmonary venous flow, which is high in oxygen content, to the systemic flow, which is low in oxygen content. Another type of balloon, we have to do it in the cath lab, which is the Z5 balloon, and also we drag it from the left atrium to the right atrium, taking care not to injure the inferior vena cava. This is not always straightforward. We have to do it also in the condition where there is an obstruction to the pulmonary venous blood, and like in situations with mitral atresia or hypoplastic left heart syndrome. This is a patient with obstruction of the mitral valve, so the only egress of the pulmonary venous return is through this small ASD. We have to enlarge this because these patients suffer from pulmonary venous hypertension and again arterial hypoxemia. So we introduced the balloon in this small left atrium, which should be a tough balloon because this atrial septum is thick, and we succeeded in creating a large ASD with a laminar flow between the highly oxygenated and the non-oxygenated blood. Sometimes you have to do a dilatation of the atrial septum in situation also with hypoplastic left heart or a TGA. We have these patients with almost intact interatrial septum, and he's about to die because we have to make an egress for the pulmonary venous return to be mixed with the systemic venous return, and this is very tough. We cannot introduce the regular balloons like the Rashkind or the Z5, so we introduce a coronary guide wire along with a coronary balloons, 2 millimeters. We done dilatation of the atrial septum. Of course, this was done in the cath lab. And then we succeeded to make this small hole through which we introduced the Rashkin balloon and to create the atrial septostomy. Another type is the pulmonary valvuloplasty, pulmonary valve stenosis, and the criteria for interference in the neonatal period, we should have a critical ductal dependent pulmonary stenosis or a severe pulmonary stenosis, not ductal dependent, but there is a suprasystemic pressure in the right ventricle, and there is cyanosis because of right to left shunt across the PFO. And this is example of the severe pulmonary valve stenosis, severe hypertrophy, severe tricuspid regurgitation, but there is a forward flow across the pulmonary valve, and there is a balloon dilatation. Again, there is no waste, and we succeed to improve the stenosis. Sometimes we are dealing with almost atresia. Here are the patients, the neonate 3 days old, and there is no flow across the pulmonary valve, and there is a suprasystemic pressure of the right ventricular pressure, which is higher than the aortic pressure, and this is a gradient between the right ventricle and the pulmonary valve. So it's very increased. This is about 80, and this is suprasystemic pressure, so we have to intervene. So these patients, we introduced a coronary guide wire through which this was a pinpoint orifice of the pulmonary valve, balloon dilatation with a coronary balloon, after which we succeed to enter the mini Tyshak balloon, which enter along a coronary guide wire, and we succeeded to decrease the right ventricular pressure below systemic and decrease the gradient to 25 millimeter mercury. And this was a 3 days old newborn. So this is injection. Afterwards, we established a forward pulmonary blood flow. The pulmonary arteries are filled very nicely. Another type of interventions is the aortic valve stenosis in the neonatal period, which is now the results are comparable to the surgery in terms of if we develop aortic regurgitation. So now this is the established method. And we are choosing our patients if they are going through a biventricular repair through the left ventricle, and this is done through echo. The left ventricle long axis to the heart long axis should be not less than 0.8, an indexed aortic root diameter of 3.5, indexed mitral valve area of 4.75, and left ventricular mass of 35 grams, so to avoid those of the hypoplastic left heart variants. So these patients with a severe aortic valve stenosis, we introduce a balloon across the aortic valve, and this is the injections after the aortic valve, only a whiff of aortic regurgitations. Sometimes this is not all a piece of cake. We have to go through another approach. We go through the carotid arteries. This is a duct, and why this? Because these patients have a very hypoplastic femoral arteries and iliac arteries. So we introduce through the carotid artery, and we succeed to balloon dilate the aortic valve, and in fact it gives a better position of the balloon. And we did a balloon dilatation of the aortic valve. And this was a 10 days old neonate. Aortic coarctations, the indication for intervention in the neonatal period for aortic coarctation, usually surgery. Surgery should be done for the first 6 months, but sometimes we have to intervene by balloon dilatations whenever there is indication for intervention, which is usually whenever there is a severe left ventricular dysfunction, unstable hemodynamic conditions, or severe pulmonary hypertension, or there is a recent intracranial hemorrhage, or there is a major systemic condition that makes surgical repair is difficult, like sepsis. So this is the indication for intervention with balloon in the neonatal period. And we have I give another example, which a newborn, we have interfered after 6 months with the balloon dilatation because he undergone surgery in the first 6 months. So this is a severe aortic coarctation, lateral view, and we did a balloon dilatation of the aortic coarctation, and this is the result after balloon dilatation. Another intervention is a hybrid approach for complex congenital heart disease. And by this I mean ductal dependent systemic blood flow, the hyperplastic left heart syndrome, or a ductal dependent pulmonary blood flow, which is pulmonary atresia, intact ventricular septum, or the hypoplastic right heart syndrome. In hypoplastic left heart syndrome, there is hypoplasia of the aorta or the mitral valve, small left ventricle. The systemic circulation is maintained by the duct through the pulmonary artery. And the surgical approach for this was the Norwood procedure, which is, carries a high mortality rate, and not all the centers are doing the Norwood procedure. So the hybrid approach has been developed in doing a stent for the duct and doing bilateral pulmonary arteries. And we were the first to develop this technique in Egypt in 2008 after taking a course with Aldo Castaneda. And this is our cardiac surgeon, Professor Adel Gamal. So I'm presenting a case whenever there is a variant of the hypoplastic left heart syndrome. There is a VSD and there is a small left ventricle, a very small arch, and this left-sided aortic arch with very small arch. And there is a duct here which maintains the systemic circulations. So there is a retrograde flow across the arch, and also the systemic circulation is maintained by the duct. So we took him to the cath lab. We transferred our cath lab to a hybrid cath lab. This is the surgeon have opened the chest. It's not an open heart surgery. He did a bilateral pulmonary artery banding. And then came my role. So we are doing this hybrid approach. We have introduced this sheath into the right ventricular outflow tract. This is the surgeon holding the sheath on the top of the table. And this is the sheath direct into the heart. And we are injecting, we did a multi-purpose catheter injecting direct into the heart from the sheath. And this is the injection. This is the multi-purpose catheter direct with the pulmonary artery and the duct. We measured the duct and we introduced a peripheral stent to keep the duct going.
I'm sorry for the interruption, Professor Marsafawy.
Okay, sorry. And this is the injection. We injected, this is the duct and this is a bilateral pulmonary artery banding. This is a pulmonary atresia. This is a patient in which there is no forward flow from the RV to the pulmonary artery, and there is no valve even to show. And we get this patient to the cath lab. His pulmonary blood flow is dependent on the duct. We introduce into a coronary guide wire with a coronary balloons into the duct to keep the duct going. This is a substitute for the modified BT shunt. So we can do the shunt later, or we can take the patients for a Glenn operation or a permanent biventricular repair. So this is injection through the duct. It maintains the pulmonary artery blood flow. So the factors improving the outlook for a newborn with a critical congenital heart disease is an early diagnosis. Now we are doing this in the fetus. The proper diagnosis with sensitive echo machines, and we don't do diagnostic cardiac cath anymore in the neonates, only interventional. And there is improvement in the transport facilities to take these sick neonates into tertiary hospitals. And also there is availability of pharmacologic manipulation of the ducts through the prostaglandin E1. And there is rapidly acting intravenous inotropes. And there is ventilation to manipulate the pulmonary vascular bed and the pulmonary vascular resistance. And there is so many intervention procedures, balloons and wires, and also in the closed and open heart surgery, and the integrations between the interventional cardiology and the cardiac surgery, and also the learning curve of the neonatologist, the pediatrician, the pediatric cardiologist and nursing, and the cardiac surgeons is increasing regarding predicting an immediate diagnosis and emergency management of the neonates with a critical congenital heart disease. And thank you so much for your attention.
Thank you very much, Professor Marsafawy. We have the next 8 minutes for discussion. It's over to the chairpersons.
That was a very elegant presentation by Hala. Hala, you showed the septostomy where the balloon is pulled. And our own Dr. Savitri Srivatsav has come out with the static balloon dilatation, where you don't pull it, you don't tear it, you just dilate it, and then you get the results. And you showed a very nice presentation about the critical aortic and the pulmonary stenosis also. Especially in the newborn, if there is a hydrospitalis, it can be a real challenge, but it is literally life-saving. Thank you very much.
Well, mine is not a question. The topic of Smita Mishra was very intelligent, was very important from the general audience point of view. Now we have a cream of national and international pediatric cardiologists here. Within 1 or 2 minutes, can they tell us about the perimembranous VSD surgery versus device? Because now many of the intelligent patients ask us this question. So at least it is of interest to everybody.
So like it's very important thing like perimembranous VSD closure. The latest development in technology is, as I told you, is now the availability of a device called ADO2, which is the amplified duct occluder 2, which is pretty useful, and that actually the major problem with perimembranous VSD device closure have been congenital complete heart blocks. The complete heart blocks have been the biggest problems. So this device presently doesn't lead to complete heart block. It's not been reported to be associated with complete heart block. But the caveat here is it can close only VSDs up to 5 to 5.5 millimeter. So absolutely we have to be very clear, like small VSDs can be closed provided there is definite evidence for volume overload is there. That means LV volume overload should be there, and a QP by QS of at least 1.5:1 should be there before you start closing all these VSDs. If there is no volume overload, no other complications of VSD, I think there is no evidence to say that they should be closed, even though technically they can be closed in today's time. So but large VSDs primarily is generally a surgeon's field. A large VSD in a small kid, infant, it should be generally by and large should be a surgeon's field.
So that means you will do a cardiac cath in all these cases.
Yeah.
To find out QP, QS, you will do a cardiac cath. So is it being routinely employed now by the pediatric cardiologist, this closure of VSD?
I think you can get a fair idea of whether it is 1.5 or more by echo. Because echo will give you the left ventricular dimensions, and if they are beyond plus 2 Z value for that child, you'll have a fair idea. So I think you don't really need to take them to cath lab for QP, QS, all of them. Yes, there would be a small number of patients where you may still be a little doubtful and you may want to do a cath. But I think majority of the cases you can make that assessment and then take them to the lab if you feel it is important. Just one point I wanted to add to Rama's statement was that if there is an aortic valve abnormality or a prolapse, which is something that actually reduces the VSD size, this device is not to be used because it will interfere with the aortic valve, and that is the major side effect of the devices, that it should not produce any aortic regurgitation. So one has to make sure that the aortic valve is away from the defect.
We are closing the perimembranous VSD using either AGO1 or AGO2, but not all the patients are subjected for this. We have to have, like my colleague said, a volume overload on the left ventricle, and again the weight is over 15 kilos. So this child now is growing. As long as he grows, there is a lesser chance for closing this VSD spontaneously. So we have to intervene by closing by device as long as it's suitable to alleviate the risk of infective endocarditis and the volume overload on the left ventricle. And not all kinds, like my colleague said, whenever there is a prolapse of the aortic valve, we don't close. This is for surgery.
Well, Vijay Lakshmi has a lot of experience with the device intervention. Let's see what, Vijay, you would see the role of device.
Sir, I have the largest series published in the interventional journal, 80 cases of perimembranous VSTs, and if they are less than 6 millimeter, we use the ADO2. If they are less than 12 millimeter, we use the perimembranous, either asymmetrical or symmetrical devices. The advantages, like Dr. Ramkrishna said, is ADO2 is a very soft one without any polyester material. So conducting problems are much less compared to the surgical. So in our case, only one patient required the pacing for only 48 hours, otherwise rest of them they were not. And the Gerbude defects from LV to RA, they have to be closed even if the QPQS is not much. And I think echo measurement may be wrong, because when the cusp prolapse is there, we are underestimating the VST defect. So the defect less than 12 millimeter will go with the device closure. Anything more than that will go for the surgery.
I have just a question to Professor Sonia Saidi, which is an elegant presentation. You used the multi-slice CT in a newborn child, and you know the stochastic and deterministic effect of radiation. Is there a certain indication to use multi-slice CT with these high radiation hazards, or better to serve it for coronary angiography for imaging and intervention?
Multi-slice CT is quite safe, and we use it even in the neonatal period. Our patient was not a neonate. She was 1.5 years when she first got the multi-slice. But we use the multi-slice even in the neonate. As long as the radiation time between the cath to be done and the multi-slice is more than 2 weeks, it's okay. The problem is there when you have to take the patient to the cath lab and he has done already the multi-slice CT, too much radiation dose, so you have to limit the radiation time in the cath lab to the minimum as much as possible. The timing between the two is the trick. If it exceeds 3 weeks, it's okay, and it's safe. So it's not a problem to do in the neonatal or pediatric care.
To put one comment about your case is, like, maybe this may not be a real coarctation in real sense. This could be something called the mid-aortic syndrome. So where actually this kind of a disease, thoracic aorta and lower down, everything is disease and everything is small. So that's very well known to be very resistant to balloon angioplasty and resistant to even surgery.
It was like interrupted aorta with cord-like segment, but it ended up so well because our surgeon used this cord to give her a normal aorta that will grow. This aorta will grow that she ended up with had a little bit segment of her normal tissue that can grow with time, and that's why she at the end she responded, and we have put the stent that is dilatable to adult size, and this aorta will grow, but we cannot ensure the return of function to the LV after it was damaged, but it is much better.
So for the Indian audience, like, such lower down coarctation can occur in 2 more diseases. One is our typical Takayama-arthritis, that the aorta-arthritis occurs in slightly older children, but they often present with acute decompensated heart failure and lower limb pulses will be absent. Even though if you see echo, there won't be any coarctation, but the typical area where the near about diaphragm, the narrowing will be there. Another rarely it could be seen with the neurofibromatosis. Like, sometimes we can have neurofibromas presenting like thoracic narrowing.
She has used the stent, the Palmar-Stat, but now we have got a biodegradable stent as well as the growth stents, which will dissolve, and then later on that can be further dilated. And that possibility is also there.
I just want...
Is it present for use in the market? No, it's not.
Hala?
I want to add that the highest dose of radiation through the cath lab is the cath lab. So it's better to, and the modern CT machines have now less dose of irradiation, especially the spiral with 128 or 256, a less dose of irradiation. So, of course, we have to lessen the dose of irradiation that these children, because this is just starting her profession in the cardiology practice. She will be followed by a series of irradiation.
My question, there is definite stochastic effect of radiation for this age group, which can change the genetics and do a serious thing in the remote after
they have a life expectancy.
Sorry, Dr. Hala, you get a very excellent presentation, but I am, just because I work in this field for nuclear cardiology sometime and for this. So my question, if there is any other test like MRI that can, without radiation, especially in those age group, this is my question.
Can I answer you? There is a limitation of the radiation dose, and it is calculated. And even when we are working, if the time exceeds in a neonate 1 hour, we have to stop and abort the case. There is a radiation dose, and it is measured by gyra and time. And it has to be monitored throughout our work. And that when we reach the limit, we stop, even if the procedure is not completed, and we come back in a couple of weeks to do it, in order to avoid any damage to the systems that can be in a neonate affected by the radiation. The radiation is monitored.
Sorry for the interruption, Mr. Chairman.
Thank you very much, ladies and gentlemen. I think let's give a big hand to all the 3 speakers, Anita, Sonia, and Hala, for a wonderful job. And I think
and thank you very much, sir. The Parliament has not given 33%, and you have given 100% to women.
And I think the best thing is, like Dr. Parashar generated a lot of interest, despite Smita being not here, but the subject was greatly discussed. It is of a great clinical relevance. When to use prostheses, when to have surgery, what are the controversies of QP, QS. I think everything was addressed. Let us call the chairperson, Dr. Vijay Lakshmi and Ramakrishna, to please, Rama,
and present the mementos. May I firstly request Dr. Chopra to kindly present the memento to Professor Saxena. Next, I'd like to invite Professor Vijay Lakshmi to present the memento to Professor Sonia Ali El Saidi. I'd request Professor Sonia to please step forward and accept a memento from Professor Vijay Lakshmi. May I invite Dr. Ramakrishnan to present a memento to Professor Hala Marsafawy. Professor Hala, if you could please step forward and kindly accept the presentation. We'd like to thank the chairpersons for this session.